Okay, this is part B of chapter 20. So here we see some illustrations of some different circulatory routes. The simplest pathway is, or most common route, is heart, arteries, veins, heart, arteries, capillaries, veins, and then back to the heart. However, it's not the only type of route. The second example is called a portal system. Blood is going to go through two capillary beds after leaving arteries and before going into the final vein pathway. Now, there's different kinds of portal systems. Sometimes the blood vessels in between are arteries, sometimes or arterioles, and sometimes they're veins. Sometimes the two capillary beds are close to each other, and sometimes they're farther away. In the kidneys, we see two capillary beds connected by an arteriole, and they're fairly close together. Down here at the bottom, you see an end-to-end anastomosis, where the arteriole is flowing directly into a venule. So there's not going to be exchange here. And this can happen when the blood pathway needs to be rerouted. And so there's a capillary bed that gets avoided to get more blood flow to an area. All right, a specific portal system that we're going to need to take a look at is the hepatic portal system. The hepatic portal system has a capillary bed in various places. It's going to receive blood directly from the stomach, both intestines, the spleen, and the pancreas. That's where all of the first capillary beds are. Then you have a series of veins converging into the hepatic portal vein, which is going to go into the liver, which then filters the blood before it going back into the bloodstream. So the liver represents the second capillary bed. So the hepatic portal system is a defense mechanism. If we think about what's coming out of the stomach and the intestines, we're digesting materials. So the materials that we consume and have broken down are going to enter the hepatic portal system to go into the liver to be filtered out. So that the liver can deal with those materials, reconfigure them, and dump them into the bloodstream so we can use them in the cells of the body. The spleen is filtering out antigens and dealing with them, and so that goes to the liver so that it can deal with those antigens and make them less harmful. The pancreas is secreting hormones, and the liver needs especially glucagon and insulin both of them, to metabolize certain nutrients. So it's a defense mechanism. It's a way to get filtered materials to somewhere that can process it and make them either less harmful or usable by the body. So, distribution of blood in a resting adult. 64% of blood is in the systemic veins. And like we do with most things, we're going to go from largest to smallest. 15% of the blood in the body at rest is in the systemic arteries. 9% is in the pulmonary circuit. 7% is in the chambers of the heart. And 5% is in the systemic capillaries. All right, now over the years, the biggest category and the smallest category have always stayed the same. These three other ones have kind of wish-washed and changed over the years. Systemic blood pressure is the force exerted by the blood on the vessel walls throughout the entire body. So all of this graph is systemic blood pressure. There are three things that determine systemic blood pressure: cardiac output, total blood volume, and resistance or friction. So, cardiac output, the amount of blood coming out of a ventricle per minute, if that raises or is high, then that systemic blood pressure is going to be high. So there's a direct relationship or direct correlation between cardiac output and systemic blood pressure. Total blood volume, same type of relationship, direct. Total blood volume is high, systemic blood pressure will be high. If total blood volume is low, then systemic blood pressure is going to be low. Resistance or friction. Resistance is going to have an inverse relationship. If you have more resistance, you're going to have less pressure. If you have less resistance, you're going to have more pressure. So reverse, inverse relationship. Now, if we look at this graph, it again illustrates that most of the pressure is in the arteries. There's a medium amount of pressure in the capillaries, and the least amount of pressure is in the veins. Clinical blood pressure is measurement of force at a single large artery, typically the brachial artery. So if all of this is systemic blood pressure, this is clinical blood pressure. It's a snapshot. Typically, the brachial artery is the ideal site because that's where the blood pressure is most often taken. Yes, it can be taken at the wrist, but then you're using smaller arteries. It can also be taken on the lower leg or thigh, depending on the size of the individual. So, normal adult ranges. Systolic pressure, average 140 to 95 millimeters of mercury. And it's a range. So the force exerted when the ventricle contracts is going to average in there. Diastolic pressure is 60 to 80. This should be an 8. Oops. Okay, it should be 80, not 90. And that's been in the last 5 years that they've changed that. So that's the force exerted when the ventricles relax, diastole. Now, it's written as a fraction. So you also have to take in consideration the difference between the two. The average of both ranges is that 120 over 80. You have a pulse pressure of 40 millimeters of mercury. Again, numbers don't mean anything if you don't have the unit of measure. Now, if we take a look at the blood pressures of 140 over 60, yes, that falls into the average range, but it's not good. Neither would 95 over 85. These are too close. These are too far away. So you have to look at the distance between the two numbers, not just the two numbers. Typically, our blood pressure is going to drop as we get older until we reach older adulthood, and then it's going to start going back up. That's because as we age, our blood vessels are less resilient, our heart is less resilient, we're wearing out. So blood pressure, clinical blood pressure, is just a snapshot of systemic blood pressure. All right. Resistance, one of those 3 things that determine blood pressure. We're going to take a look at a closer look at, or take a closer look at that. Resistance is the friction or physical contact or interaction between the blood and the vessel wall. The vessel wall is stationary and the blood is moving, dynamic. So again, rubbing your hands together causes heat to build up Eventually, you will start losing skin cells. Resistance is why you get a blister with new shoes. Okay, there are three things that determine resistance. Excuse me. Blood viscosity, or the thickness of blood. This has an indirect proportion response or indirectly proportional effect. So if blood viscosity is high, resistance is low. If blood viscosity is low, then the resistance is high. And this is kind of counterintuitive. The thicker the blood, the more resistance. The thinner the blood, the less resistance. Or the thinner the blood, the more resistance. So it's like slick shoes on ice or having traction on ice. It's easier to slide on ice if you don't have traction. So it slides easier. So thickness of blood, viscosity of blood, two things determine the viscosity of blood. And we described that in chapter 18, hematocrit and albumin levels. The second component or determining factor, vessel length. The length of the vessel is proportional to its resistance. The longer the blood vessel, the more resistance. The shorter the blood vessel, the less resistance. All right, so that's why you see lots of branching. In blood vessels. Vessel radius is indirectly proportional to resistance. And that's what we're seeing. Oops. That's what we're seeing here. The larger the lumen, the less resistance. The smaller the lumen, the more resistance. Smaller lumen, you have more contact between the blood and the vessel wall. Bigger lumen, less resistance because there's less and less contact. Okay. Baroreceptors. So this is part of regulating. Baroreceptors, and we talked about this before, in the aortic arch and the internal carotid arteries detect blood pressure. They transmit those impulses to the medulla oblongata. There is a vasomotor center right next to the cardiac center in the medulla oblongata. This is going to send impulses that can either vasodilate or vasoconstrict to change the blood pressure. So vasoconstriction reduces the volume, increases the pressure. Vasodilation increases the volume, decreases the pressure. Blood pressure is regulated with a negative feedback system. So, hormones to help regulate blood pressure using vasodilation and vasoconstriction. Epinephrine and norepinephrine are neurotransmitters used by the sympathetic nervous system to cause vasoconstriction in the skin and blood vessel arteries. It's going to cause vasodilation to the skeletal muscle arteries. Angiotensin II is going to specifically affect blood vessels in the kidneys. So, vasoconstriction or a vasodilation in the kidneys. Other hormones are going to change water loss through urine. The natriuretic peptide is going to make us get rid of water. Aldosterone and antidiuretic hormone are going to help add water. Okay, so A's add water, so that's going to increase blood pressure. Natriuretic peptides, like a diuretic, are going to lower water levels to lower blood pressure. All right, so that's the end of chapter 20.